Good afternoon. Welcome to this webinar. I'm Scott Jamison. I'm one of the physicians here at POM. I joined POM in May of 2019. I'm an internal medicine board certified and functional medicine certified physician. Today I'm going to talk a little bit about good preventive health models using both sort of the traditional preventive task force recommendations and try to tie in with that some aspects of more of a functional overlay, or how functional medicine kind of fits into the model of proactive preventive healthcare. I'm going to give just a few seconds here to make sure we've got everybody up and running, and we'll join from there. This will be sort of a brief overview of everything that is out there. And again, I've got some new ideas and some new tests that are coming up that I'll throw into the discussion. So with that, I think I'm going to go ahead and see here if we can share the presentation. So I'm going to give, like I said, a brief overview of the preventive healthcare recommendations and try to put that into really a broader sense of what we do here at POM and in functional medicine. And I think a couple of just minor points that I try to keep in my mind about what preventive healthcare is. There are layers of preventive healthcare that are just that we're taking on actions trying to prevent the development of an abnormal health process or disease state. And then a lot of the so-called preventive recommendations are actually early detection. So mammography, colonoscopy, you're really looking to not necessarily prevent those diseases, but early detect at a stage when it can be dealt with at a much quicker time. And so I think those are kind of an important concept to keep in mind as we go through some of these recommendations, and particularly as we broaden out into what I think some of the future holds for a more proactive protocol for preventive lifestyle and medical care. So I think some of the important concepts are, as we do in functional medicine, is truly understanding that every person is unique and everybody therefore has an individual risk for certain conditions and disorders, and as well a resiliency that may be different from one person to another in terms of their susceptibility to developing a certain illness. Preventive screening in the very classical sense is really there to detect and identify an underlying issue before it becomes a overtly clinically active process. So again, finding an early breast lump, finding an early precancerous polyp. We've gotten to a point in medicine, and it's only going to get better, where we can start to look, and I think we're really just a tip of the iceberg right now, really begin to look at genetic testing to help formulate on a genotypic analysis what is a person's at-risk status. I think it can put a lifetime risk onto the model of how we follow people, care for people, maybe personalize their care. But I think genetics really often concern me because it's really never a for sure thing. It's really just what the potential is there. And the majority of the expression of that genotype really becomes down to a variety of non-genetic factors. So the genetics can be very helpful to give us an at-risk status for certain diseases, disorders, but it's just that it's the at-risk, and then those are certainly very modifiable risks. So the benefit of testing early and knowing what those genetic risks are. I do think that, and I'll bring up a couple of examples, there's some new on the horizon, and one test in particular is now here, that really are doing, really taking some of this genetic molecular biology a step forward to enhancing really more individualized early detection. There's a test I'll talk about towards the end that really takes a step back and doesn't look at genetics, but it looks more at epigenetics, which is how genes are manipulated or modified by nutrition and environment and toxins in a way that allows them to express in a pathologic sense. And the particular test in mind is one that may have real capacity for the early detection of multiple cancers at a stage. Again, the goal is not necessarily preventing with this test those cancers, but early detection at a time when those can be more easily treated, and more will be coming in this regard, and dementia and so forth. There'll be a number of conditions that'll come out in this regard. So that's sort of the broad overview of what we're going to kind of throw into this mix as we walk through. The slides I have are pretty traditional preventive stuff, and then I'm going to try to bring in a little broader overlay of each one. Now I've got to figure out how to advance the slide. There we go. So I think, in my perspective, and certainly from a functional medicine point of view, that lifestyle factors are truly the, I guess, basis of good preventive healthcare model. We know that lifestyle medicine affects genetic expression. We know that how you are in a mind, body, spirit sort of way can affect everything from adrenal function to thyroid hormone levels, all of which can affect the development of certain diseases and disease states. And so what we do in functional medicine for a good preventive program is really look at each of these lifestyle factors. And this is things such as stress management, meditation, biofeedback, neurofeedback in some cases. We know that stress is something that, certainly chronic stress in particular, is something that can increase the risk of diabetes and dementia and stroke and heart disease and probably certain cancers as well. So this becomes a real point of traction that very early in someone's life, working on developing good lifestyle habits of meditation, biofeedback, just good self-care can go a long ways to this broader preventive approach to a person's health and wellness. Sleep, relaxation models fall into that. We'll discuss a little bit about sleep apnea. We know that good sleep, bad sleep can make big differences in the risk of dementia and probably high blood pressure and a few other, and probably actually many other medical conditions. The obvious things, not smoking, tobacco utilization in general, alcohol in excess. The World Health Organization has kind of labeled, and I don't like this, but have labeled 2 drinks per day, kind of the upper limit for men, and 1 drink per day for women. Above that, there's a discernible impact on the health status. I think in reality, there's probably no amount of alcohol that's totally benign. But I think the main point here is being aware of alcohol and how you consume it, if you consume it, patterns, excess, and so forth. Exercise, again, one of those important lifestyle things that it has so many metabolic benefits, but it also stimulates, for example, BDNF in the brain, which is a potent neurotrophic factor. And so there's these correlations with having more exercise or lack of exercise and dementia and cognitive function in later life. Diet, there's a wide variety of diets that have been looked at, and I guess the most famous being the Mediterranean diet in terms of its ability to reduce metabolic illnesses, but also longevity, life and lifespan quality. There's data, and I don't, certainly not a time to go into that, but that fasting may be of some real benefit. We have a program here that's a Walter Longo's Prolong, which is a fasting mimicking diet, and there's some very interesting data on that, on prolonging lifespan, but also, more than just prolongation, the quality of lifespan, less metabolic disease, diabetes, heart disease, so forth. So there's some real, I think, very powerful data about time-restricted feeding, intermittent fasting. Obviously, avoiding obesity is critical. We know that obesity is correlated with a number of lifelong medical conditions, and particularly as we measure here POM on our body composition analysis, the what's called the visceral adipose tissue, the fat around the organs, that correlates well with a lifetime risk of a variety of conditions, diabetes, heart disease, dementia. One thing that I'm very interested in is sort of lifetime toxin exposure and its impact. And we know that in addition to the acute illnesses that can happen from heavy toxin exposures, and that can be heavy metals, that can be tick-borne illnesses, that can be mold illnesses, environmental toxins. These are all things that modify, again, can modify genetics, can modify our endocrine system, affect our thyroid gland, affect gut function, and that burden of a lifetime or a total toxic burden can be correlated again with good health, bad health. So I think that's really important to keep in mind, and we talk about that as we talk to patients about what their risks are. A topic that I put in here that I've become so increasingly aware of in the last 4 or 5 years is the history of psychological trauma, or PTSD. There are increasing studies that adverse childhood events and I think even adult adverse events is correlated within a person's lifespan, I should say, of a number of at-risk, having a higher risk of chronic medical illness or disability. And so I think, and this is something that can be modified through appropriate therapy, neurofeedback, other type of brain retraining programs. So I think that again, that self-awareness of adverse events can be very helpful in developing a really broad, appropriate, personalized form of intervention in the preventive sense. This always starts with us with, going through the history, or what's the family history. Again, everything about travel history, exposure history, worked in what factory or not, exposure to chemicals, et cetera. So a good history always helps us get that protocol set into place. And physical exam, you can pick up, skin lesions, you can pick up a carotid bruit that can be a sign of an advancing atherosclerotic lesion of the carotid arteries, heart murmurs, and so forth. Routine labs, these get included in this because we're looking for markers that help us understand where somebody is at the time the labs are drawn with regard to their metabolic status. Where are they with their lipids and cardiovascular risk? Do they have early markers for insulin resistance and therefore the risk for diabetes? As we in functional medicine evolve a little further, we dive a little more into nutrition, and we've got a number of marker tests that help us understand beyond even just the simple vitamin D, vitamin B12 levels, really looking at how nutrition is occurring and maybe disordered in any one individual. Another thing that we I would say pretty much most often check on most of our patients are markers of inflammation. We know that chronic inflammation is an underlying fundamental process that sets a patient up for an inflammatory process that will change mitochondrial function, gut function, and puts that patient at risk for developing chronic illnesses and certain cancers. So inflammation and how we approach that is very critical in a good preventive protocol. Genetic markers, as I mentioned, the 23andMe's, these things that can give you sort of a summary of what are some of the high point genetic markers for an at-risk status. That, along with family history, can be very helpful in setting the stage for, we need to focus on this more than this because of this genetic risk. Organic tests is what I mentioned earlier. We have a number of tests that we're really looking at everything from toxin burden loads to how the mitochondria are functioning, how the gut's functioning, and that's where the stool studies come into play. And there's, again, a number of studies now that are showing that certain bacteria in the gut can be associated with the risk for autoimmune disorders such as rheumatoid arthritis, ulcerative colitis. The data on the gut microbiome is just exploding over the last few years, and I think will continue to be refined to a point where we can really look at someone's gut microbiome and use that as also a marker of what are some at-risk status issues, and also by modifying those issues in the gut microbiome result in a therapeutic reduction in those risks for many of our patients. One of the first areas that I'll just kind of focus a little bit on is cardiovascular disease prevention. Obviously, a major cause of mortality and morbidity in this country and around the world. Again, it's a lot of the same sort of variables that we're looking at. We take an individual patient, we're looking, as we sit down and develop what's a good preventive model for this patient, we're looking at, again, family history. Did brother have a heart attack at 50? Did multiple male family members have sudden death, et cetera? That family history gives us a good sense of where are we from a genetic standpoint. The original data was, male versus female, that males were more at risk. That's, I think, beginning to really equal out and probably not be as critical. We want to look at really where are they lipid-wise, and we have some more advanced ways of looking at that rather than just the traditional lipid panel. We'll talk about that in a minute. Do they have high blood pressure? Are there other issues present? Diabetes, elevated triglyceride, metabolic syndrome, which used to be termed pre-diabetes. Again, as we talked about, that fat around the organs sets a patient up for insulin resistance. That puts into cascade a flow of inflammation that in its final or later outcomes can result in true diabetes. How active is a patient? Patient is very active versus non-active. Those put us into different risk categories. Homocysteine is a marker of methylation pathways that can be tied in with the B vitamins and it can be associated with genetic issues such as methyl tetrahydrofolate reductase abnormalities. And knowing if somebody is MTHFR positive and they have a high homocysteine level, that increases the risk for certain atherosclerotic disease such as stroke and heart attack. Again, family history, I mentioned being important. Again, tobacco use, stress is critical. A woman, are they postmenopausal, premenopausal, and then all of the inflammatory markers that we look at in this approach. So from a prevention, it's kind of taking all of those things and flipping them around. Once we have somebody's risk status sort of beginning to unfold, and really we want to get optimization, blood pressure, what can we do to lower cholesterols and the various ratios and LDL particles that I'll discuss in a minute. How do we decrease inflammation? And that is often diet and supplements, stress management again. Weight loss, if that's pertinent with a good Mediterranean diet or one of the other healthy diets that we talk about. And there's some autoimmune and anti-inflammatory diets that may also be pertinent in some of these cardiovascular risk patients. And then again, a really fundamental bottom line for me is really back to lifestyle. How do we develop healthy stress management? Resiliency is so important in how we all handle stress, because everybody has stress, and it's a matter of, do you handle it well, handle it not well? What is your physiologic reaction to the day-to-day stressors that we do? We want to look at good exercise program, both aerobically, such as walking, running, swimming, biking, et cetera, but also adding in weight training. There's some increasing data that intermittent weight training may also be a preventive or reduction of cardiovascular risk. Sleep management, again, kind of critical as a fundamental thing, a fundamental factor in so many of these preventive protocols. But somebody with severe sleep apnea is, again, much higher risk for issues with cardiovascular system dementia. And classic studies showing that meditative practices can significantly reduce cardiovascular events. And if you smoke, you got to stop. Tobacco it's just one of those things that has to be dealt with in this preventive model. Some more advanced sort of, I guess, what we would call risk stratification variables. There are some advanced lipid testing that I'll cover in a minute that gives us more information than just the standard traditional lipid panel. But a couple of things that we've had that I think have had very good benefit from using is a carotid vascular or ultrasound. And we have one, and it's available other places, but it's one that's more specialized than just looking for blockages in the artery. It's going to look at what's called the carotid intimal thickness. And this is the thinness or thickness, the width of the inner lining of the carotid artery. And there are good studies that correlate that with aging. A more advanced carotid intimal thickness score is a forward-looking measure of what somebody's vascular health is. So if I have a 50-year-old person with this, let's say, borderline cholesterol, normal other risk factors, but has a vascular age of 80, that's someone that I'm going to be in tune with being a little more aggressive with their preventive protocols, with both supplements, exercise, these lifestyle factors, perhaps even statins in the appropriate case. So that carotid, and likewise the reverse, if somebody's 50 or say 70 and their vascular age is 50, then that's reassuring that they're, or it helps us put them into a lower risk category. Similarly, we look at something called a coronary calcium score, which is a scan which gives us an indirect indication of how much calcium, and therefore we think plaque, is in the coronary arteries of someone's heart. And again, it's just like the CIMT score. If somebody has a very low calcium score, that we think correlates with a lower risk for a cardiovascular event. And none of these are exclusionary. I mean, we all see people who do all the right things and their labs look good, and still events can happen. But the coronary calcium score, if it's low, is helpful. If it's very high, then that's something that we again look at intervening with lifestyle approaches. Do we need other supplements for reducing vascular inflammation? Do we need statins in some cases? We have a couple supplements that I've used very successfully to reduce calcium scores and CIMT scores. Other important things that are included in the recommended or protocols and I think are helpful is screening for an abdominal aortic aneurysm. In the current model, that's done about age 60 to 65, unless somebody's a smoker or someone has a family history of an aneurysm. And it's a simple ultrasound that's done of the abdominal aorta. And we're looking for any dilation of that. And again, the issue is, again, to catch it early. We know that exercise and good control of blood pressure can either prevent these from happening in many patients, and if they have an aneurysm, those kinds of controls can help us prevent them from enlarging and becoming more at risk and needing attention or the risk of an aneurysmal rupture. Screening for peripheral arterial disease, I will say I don't do the formal test as a routine across the board test, but we're always looking for this in high-risk patients, diabetes, hypertension, significant heart disease, or patients who have calf pain, foot pain, where they may be having an inadequate circulation. And this is where poking on somebody's pulses in their feet and ankles can be very helpful, and sort of early detection of this, along with the history of any problems with exercise and getting cramping in their calves. Blood pressure has been, again, continues to be a high-risk situation. There have been some changes in many of the guidelines. The SPRINT trial a couple of years ago lowered what are considered to be the standard acceptable blood pressure measurements or goals for patients. The monitoring of blood pressure actually, in my opinion, turned out to be more tricky. I do prefer, if somebody has an issue with blood pressure, that they have their own monitor, that we've double checked it at the office to make sure they're doing it correctly and it correlates with our readings. And these are some of the guidelines that have come out for helping us understand where somebody is in these categories of hypertension. Again, the model or the benefit of monitoring this earlier and kind of longitudinally is that if somebody's blood pressure is escalating, which is common with aging, that we can intervene before there's the beginning of damage to kidney, brain, and heart. The one concept that I think is important is that as people get into more advanced ages, some of these numbers are not as valid. There's actually some data that, in particular, people over 75 may benefit from a slightly higher blood pressure. So all of these have to be individualized and dealt with on an individual basis. But again, high blood pressure is one of those variables that's very common, puts people at risk for a variety of illnesses, and it's something we have to be aware of and monitor closely. Again, I think these are some data that everybody's pretty aware of in terms of the risk for stroke, heart disease, and chronic kidney disease just from chronic untreated hypertension. Again, I think monitoring BP in the patient who is borderline, and often people in our office or any medical office, just due to the nature of that visit, it may be a little bit higher. I like for people to have a good, and those people have a good blood pressure machine. I prefer Omron brand electronic, and I like the arm rather than a wrist monitor. And again, we want to make sure that it's been double checked for accuracy in the office against our BP machine. And then I think what I really look at is doing them a couple times a week, and depends, how concerned we are. But I like checking them at different times of the day: morning when you first wake up, end of the day, resting on the weekend, stressful day. And I'm not looking for one individual reading. It's looking for a pattern of where are we and what's sort of the net blood pressure effect. And again, I think like everything that we've kind of talked about, this is a good example where lifestyle medicine really is the bottom line, if you will, for preventing hypertension, but also treating hypertension in the early phases. And again, it's exercise, it's the diet, it's stress management, it's less alcohol, good sleep, working on reducing inflammation, supplements. We use a variety of supplements. And again, I think there's a point where medications have to be used, just because that's the only way you can get near the goals for blood pressure measurement. We live in a toxic world, and there's evidence that certain heavy metals, certain toxins can put someone at risk for hypertension. So these are all things that come into that fundamental approach to hypertension. Cholesterol evaluation, we use very frequently here at Palm a test called the Boston Heart that is a really comprehensive cardiovascular laboratory evaluation. It's hard to see on the screen, but this upper box on the left-hand side of this is the really traditional standard lipid panel that most people come in with. The rest of this report is looking at everything from omega-3 levels to the LDL particle counts. And I don't want to belabor the point, but with LDL, you can have somebody who has a borderline reading of 125, should be under 100. If they have a low particle count, meaning the number of particles of LDL floating around in their bloodstream versus the same 125 LDL, but they have an LDL particle count of 2 times normal, say 1,800, 2,000, that higher particle count puts a higher risk to that same level of LDL cholesterol. So I think that's an important concept just of how we sort of tease through this data to always trying to put things into what is a risk stratification. This test looks at omega-3 levels, which is very helpful. And it looks down the breakdown of small, medium, large, HDL, LDL, all of which wind up being very important. The Boston Heart also has homocysteine, inflammatory markers, as well. It also has some genetic markers that are very helpful that I'll show you in a minute. Again, these are the issues. I think ratios for me are a little less important now than they were perhaps in years past. To me, particle count, size of particles, do you have the appropriate number and size of the particles can be very helpful. And I think this is important with HDL. I hear often people come in and say, well, my cholesterol's high, but my doctor told me my HDL is fine and is actually elevated, so that offsets and neutralizes the elevated cholesterol. That can be true, but many of those people that high HDL actually either have small HDL particles or a hybrid, and so that total HDL is not as accurate as it looks on a standard protocol. So this is important. Triglycerides are helpful if they're particularly high, because that can be a marker of insulin resistance and metabolic disorder. Some people, this gets checked once a year. Some people probably even every couple of years. Some people it's every 3 months, depending on what kind of level of elevation, treatment, and other medical conditions they may have. We have a number of supplements that can be thrown into the mix. I won't go through each of these, but there's really a pretty reasonable body of data that many of these supplements, which are common here at Palm, are things that can lower cholesterol, but also change perhaps the ratios of small, medium, large, and the number of LDL particles. Uh, Smoking, tobacco again. I don't think there's a lot that needs to be said there. It's a given that's got to go, and there's a variety of ways to address it. I don't think that's important at this point. But if you're using nicotine, smoking, that's really a high priority in any kind of preventive model or protocol. And so then, we talk about earlier about the carotid scan, the calcium score in the heart, and all of these other variables, and we then can put somebody in a risk stratification. We know that the first sign of heart disease in a fairly significant population or percentage of the population is an event, a heart attack or sudden death. So we're always asking ourselves that question of what's the marker for an asymptomatic cardiovascular disease? And EKGs can be helpful. I don't find them as helpful as perhaps we once relied on them. They can be helpful in showing past events. They can be helpful if somebody's in the throes of an acute event. But clearly, we've all seen people who have completely normal EKG, and they're either having an event or they have an event shortly thereafter. So in that higher risk patient, then this is where stress testing, stress echoes, those are things that can really look for a functional evaluation of cardiovascular symptoms or dysfunction before it becomes an actual documented event. So we'll occasionally, in higher risk patients, diabetics, people with very high cholesterol, prior events, do periodic stress tests, periodic EKGs. We talked about this already, and their use in a forward-looking model of prevention. This is kind of what we look at. This is one of the CT calcium score, and you can see this white area here is all of the calcium in this what would be a left main, and then splitting into the two next arteries, and that's the kind of score that doesn't always correlate with having an event or having an overt blockage, but has been shown to be, again, a forward marker, looking marker for what do we do about in terms of this risk for this patient. And again, this is lifestyle medicine, perhaps statins. I've been using a supplement called Arteriosil. There's some data that it may actually, it's a natural supplement that may reduce or reverse some of this calcium deposition, may improve carotid intimal thickness scores. And so it's something that I find very helpful. These are, again, another slide that I sort of covered here. But again, what we're doing is we're looking at that lifestyle issues. Where are we laboratory-wise in that collection of data? Do they have underlying fundamental diagnoses already, such as diabetes or the family history, these types of things, smoker, et cetera, that help really put us into play of separating people into medium, low, and high risk. So dementia, Alzheimer's, obviously a major problem in the country and the world as the population ages, and we're still ongoing tons of research and looking for the magic bullet for both diagnosis and treatment of this condition. I tend to think that it's not going to be a singular gene or a singular protein. It's really this back to a functional matrix, and Dale Bredesen, one of the better functional medicine type docs who's approached this prevention and treatment of Alzheimer's, really has that. It's a huge matrix of points that get looked at for treatment and evaluation. So the risk factors, family history is critical again, and probably more so, mom was diagnosed with Alzheimer's at 55 rather than mom was diagnosed with Alzheimer's at 85. That there's probably a risk differential for the family members of that type patient. We know that multiple concussions, significant head injuries is a problem. Obviously, uncontrolled hypertension, diabetes, carotid artery can give you a form of dementia, not necessarily Alzheimer's, but can give you what we call a vascular dementia. Again, as I mentioned earlier, emotional traumas and PTSD do put patients at risk for dementia and perhaps the expression of Alzheimer's. On that Boston heart test that I mentioned, there's a test on there. It's called the ApoE4 gene, and it's important for cardiovascular genetic risk because it can be associated with hypercholesterolemia and a significant increased risk for cardiovascular disease. But the ApoE4 gene has also been associated with an increased risk of Alzheimer's. And you have two genes. So if you have an E3, E4, that's an increased risk. E4, we have both of the ApoE4 genes, is a significant risk factor from a genetic point of view. Remembering that genetics is only the at-risk stage and doesn't represent the actual expression of that risk. There are other genes that are coming out, and this is already a bigger list and will continue to grow as we continue to search into the genetics of this. So that's probably, many of these are not yet in any kind of, I think, an applicable screening sort of protocol for preventive health. When we start talking about prevention and anybody who's interested, I would certainly have them go and look at Dale Bredesen's book, The End of Alzheimer's. And he's really done, I think, the bulk of the work in this area in terms of prevention, but also even reversing early dementia. But it, again, comes down, as you'll see, many of those same variables that we've been talking about in the lifestyle approach to prevention: good sleep, stress management, exercise, good nutrition, continuing to learn. These are all things that help us become more resilient and helpful in reducing that risk of any sort of genetic risk being expressed as an actual disease. Many supplements have been shown to be helpful, both for early dementia, but also perhaps for prevention. And this is the list. And again, I think most of our patients have seen one or more of these. I think one of the important concepts that's come out of Dale Bredesen's work is really what he calls a cognoscope, which is basically getting a baseline cognitive function evaluation early in life. I don't know, is that 40, is that 50, is that 60? It depends on a number of variables. But the concept is, if we look at somebody who gets diagnosed with Alzheimer's at 70, often in retrospect, they had clinical symptoms or signs that maybe predated that diagnosis by as much as 10, 15, 20 years. And so the concept is that if we get a good, objective, reproducible cognitive evaluation as part of a preventive model based on somebody's at-risk status, and we know where we are at age 40 or 50, and then where are we at 55 or 60, we may be able to pick up the early changes, even perhaps before it's an overt clinical event or awareness or diagnosis. And that gives us that, okay, here's an at-risk situation. This is changing in terms of cognitive function, and intervention in that early phase is much better than waiting until somebody gets an overt clinical diagnosis when many of the frontal neurons are already dropping out. So I've started doing this more. I didn't do it for everybody, but I've been incorporating this more into those appropriate patients just to get us a baseline data on where are you from a cognitive function point of view. So colon cancer, and this has changed a little bit in the last year, actually changed 2.5 years ago. So colon cancer is a very common malignancy in the West. And again, I would go back to the recurring theme that lifestyle medicine is the big approach, because we know that avoiding excessive alcohol, avoiding toxins, good plant-based diet, more organic diet, less meat, less processed food. These are all things that have been shown to reduce or enhance the risk for colon cancer. And so I think, again, the lifestyle medicine becomes the foundational piece. But the concept is that we want to screen people. We want to catch things early. We want to catch a polyp before it becomes a precancerous polyp, before it becomes a cancer. And so this is that, not so much prevention like lifestyle medicine would be, but really that early detection, treatment, when sometimes a very simple procedure can change the course of that polyp from becoming a clinical cancer. The prior recommendations for a normal risk patient were to start at 50. American Cancer Society a couple of years ago decided that their data showed that there was more and more people being diagnosed with colon cancer sub age 50, and they lowered their recommendations to 45. That, unfortunately, due to the COVID crisis, there was a delay in getting that passed through the preventive task force that puts the final seal of approval on there for insurance companies. That's been done earlier this year and is now sort of the guideline. We're having a few insurance companies that are still pushing back on doing a baseline colonoscopy at 45, but that will improve as over the next 6 months, 2 years, as more and more becomes frequent. The CT colonography that came out, I've not really felt like that was a good test. The data is a little tricky. It's probably very good done in a center that does it a lot. I don't think it's something that I find applicable to the majority of my patients. Flexible sigmoidoscopy, which when I started out 30 years ago, was something we all did in the office and was helpful. The majority of cancers start in the rectosigmoid area. But you miss things beyond that, the limit of that scope. And over time, more and more cancers have been identified more proximal in the colon. So I think flexible sigmoidoscopy as a screening tool has really kind of been less beneficial, or is less useful at this point. Hemocult cards, the little stool test, I think that's probably falling a little bit off now as well. There's some more specific immunoglobulin markers that are being used. And I think the next slide I have here, talks about some of these newer tests. But the test that I think is important and exciting is the Cologuard. It is a specific set of DNA markers for colon cancer. Test developed at Mayo Clinic and has been developed into another company called Exact Sciences. But it is a stool test that measures or detects the presence of these abnormal genes associated with colon cancer. It's an at-home test. It's actually covered by insurance, even Medicare, every 3 years. And obviously, there's no risk of a PrEP. There's no risk of a colon perforation. And the sensitivity specificity, meaning how well this can pick up bad polyps and cancers, is very high, very, very useful. It can have, like every test, false negatives, false positives, but it's really a good test. And so what I typically do is if somebody's had a couple of colonoscopies that are normal, then rather than continuing to do colonoscopies where that risk of a perforation or adverse event goes up, again, this is in a normal risk patient, I will start doing Cologuards every 3 years or so. If a Cologuard comes back positive, then that really, again, can be a false positive, but that requires a colonoscopy to evaluate for the presence of a polyp or colon cancer. And so I think this is a beginning of a model that I mentioned earlier for the early detection of cancers rather than just waiting for screening techniques. I do want to make a point about Cologuard, just to be specific. They do not recommend this in somebody who's high risk, who may have had polyps, who has family history. Their data at this point doesn't work as well in the correlation with those higher risk patients. And the important thing about that test also, like so many of these, what we call machine or big data learning, AI type tests, is the more tests they do, that test gets smarter and smarter, if you will, more sensitive in picking up these DNA markers as they identify additional markers. So anyway, this is the Cologuard and some data there, and you can see it finds 92% of colon cancers. And I think that number is actually higher now. It's gotten better. And so forth. I think a very useful test. Prostate cancer is like a whole topic of itself. The really short on this is that the PSA, I think, is still a helpful test, but it's not the diagnostic test that we once thought as a screening tool that it would be. And the real short answer on that is that over a long period of time, many, many men were identified and treated for prostate cancer based on an elevated PSA and lots of treatment, billions of dollars worth of treatment. And at the end of the time, they looked at the mortality rate of prostate cancer, and it basically didn't budge. And what that implies is that this, as a screening tool and a guide to treatment, we were over-treating. And men, very commonly, if you live long enough, this is something you're going to have some prostate cancer cells. So it's become I still use PSA. I think it is a helpful test for, not for diagnosis, but for helping us understand, again, that risk factor. Again, family history and lifestyle stuff comes into play. There are some more sophisticated tests that are coming out that then get thrown into that mix. A 4K score is a very common one. There are some genetic tests that can be done to determine a man's underlying at-risk status. Cleveland Clinic has just put out a new test called ISO-PSA that I'm checking into for one of our patients. And again, it looks like it's that next generation of how do we take somebody with a PSA and determine, is this somebody that's at risk? Do we need to be more aggressive, or do we need to do what's called active surveillance and monitor those people? And these are some things. This is a common problem. The problem is that the treatments have a lot of side effects as well. Surgery has complications. Radiation has complications. And so it really is important for us to have and develop a better idea, getting back to that concept of risk stratification. What's the risk of this patient for developing a more aggressive metastatic prostate cancer? Because the majority wind up not being that. And so we want to reserve these aggressive treatments for those people who are under this risk of having a more aggressive tumor. So it's a complicated study that fortunately is continuing to improve as new diagnostic preventive testing comes available. This is a little bit of the data on the 4K score. And again, it just shows for a certain PSA in a certain age group, the breaks down what the lifetime risk of these. And so the 4K score can help put us into a category of what is somebody's long-term lifetime risk, if you will, for having a more serious prostatic malignancy. And you can see the higher the score, the 10-year rate goes up significantly, and 20-year even higher. So a useful test as we're trying to tease through what a basic annual or biannual PSA elevation looks like in terms of what does that mean for any one patient. Breast cancer, again, I would go back to the argument that good lifestyle medicine is always the best initial preventive, starting early in life. We know that alcohol and tobacco and these things are associated. There's some, obviously, that I think most people know about, some genetics that are associated with this, the BRCA genes that can be determined, particularly in family where there's a strong family history. The risk is, it's there. And we know that the exercise can change it, diet can change it, more fat, less fat, all of these variables, alcohol, again, as I mentioned. And there's some data that maybe certain toxins, particularly chemical toxins that can affect the way the body metabolizes estrogen, can also be problematic in that risk. And I'm going to have to speed up here a little bit. I apologize. And this is some issues talking about obesity and some of these other risk factors. And I'm going to get some of the genetics. And so mammography has been the baseline for this. Self-breast exam has been discussed. There's been some concerns that it's not as sensitive as we would like. I think it's still something that women should do. It's not the end all, but I've had so many women over the years find their own lump or abnormality that I do very much still recommend that for people. I don't do the genetic markers specifically unless there's a family history. Some of the genetic testing does include that in their testing. Mammography, and there's a lot of issues about mammography versus the more digital versus some of the more advanced things. There's even some people talking about thermography. So again, something that is part of that annual wellness, if you will, preventive package that we want to monitor. Pap smears, again, a lot of discussions about that and changes. And what we're looking for there is early detection of a dysplasia. I would say now also we're looking to see if a woman has an HPV, human papillomavirus, because we know that that's the association with the risk of cervical cancer. So a woman, even with a normal pap, but is HPV positive, is a higher lifetime risk for cervical cancer. So another one of those issues that can help us put somebody's risk status into play. DEXA is a screening for osteoporosis or bone density. Again, a common feature, aging, problematic more in women than men, although many men have osteoporosis as well. So I would advocate that there are many men who should have this also checked. Dermatologic screening, I think not everybody needs an annual dermatologic screening. Somebody who's fair-skinned, blue-eyed, grew up in a sunny environment, has a family history of melanoma, has had a previous skin cancer, whether basal cell squamous or melanoma, needs frequent skin checks. This has to be done correctly, pretty much whole body scan, take pictures of anything that looks suspicious, and so forth. So I do think that dermatologic screening is really critical. And this is the kind of things that we're looking for, a change in a lesion with irregular pigment, irregular borders. These are the high-risk things we're looking for. Osteoporosis risk are the things, and again, you're going to see some common denominators: alcohol use, smoking, lack of exercise, vitamin D is critical. And again, osteoporosis, osteopenia, which is a linear osteoporosis being the worst, loss of bone density is something that we can make big differences in with diet, with calcium, with vitamin D, with exercise. And so an early detection, again, through bone densities, to show us that somebody's at risk at, say, age 50, and not wait till age 75 when they have a compression fracture. These are some of the scores. I don't think they're as pertinent as I would like to make at this time with the time shortage. And some of the things that we talk about, I mean, again, I think diet, exercise are critical. Looking at somebody's medication history, what's their hormone status. These are all things that I think are pertinent in terms of our supplement. And then again, lifestyle. And then we have meds. There's injectable meds. There's some oral meds. I'm not going to go into those at this time. And I'm just going to walk through these things very quickly. But again, all the same factors: smoking, alcohol, good vitamin D, 10 to 15 minutes of some sun exposure is important. And then I think some other important things that I want to bring up in these last few minutes here that sometimes are overlooked. And I think one is oral health. And I mean, dental cavities are important, obviously, but I think it's more periodontal disease that's been associated with, or gum disease, with a variety of at-risk things, and now including there's certain bacteria that have been identified in people with gum disease that is clearly associated with the risk for Alzheimer's disease. Periodontal disease and inflammation of the gums clearly associated with an at-risk status for heart disease, stroke, diabetes. So this oral health, and there's more work coming about the oral microbiome, the bacteria in the mouth, again, like the gut, good and bad, affecting our general health. And so I think being attentive to oral health, being attentive to your dentist doing a good job, and not just looking at your teeth, but looking at your gums is really critical in that good annual. And I generally recommend it every 6 months, unless there's an issue, checkup. There is some data that root canals can be a marker or can cause certain medical conditions. So that's always something I want to pay attention to if somebody's had root canals. Eye care is super critical. I tend to recommend a few periodic checks in the 40s. If everything's fine, then at 50, I'm happy with a once-a-year check. And what we're looking for is not necessarily vision, I need glasses type of checkup, but early elevation of blood pressure or pressure of the eye, what's glaucoma, macular changes, retinal changes, things that by the time a person has clinical symptoms, they've already got irreversible damage to the eye. So I think a good annual eye checkup in the over 50 group in particular is critical to, again, detect these things early and be able to institute preventive measures before it becomes a worsening clinical condition. And that changes if somebody's diabetic, that changes if somebody has significant high blood pressure, certain medications, but I think that's a general guideline. The vaccinations, I'm not even going to talk about COVID in this, but there are, I think, good data with the pneumonia vaccines, with hepatitis B vaccines. I think the pneumonia protocols are very helpful. It doesn't prevent all pneumonias, but it can prevent pneumococcal pneumonia, which is a very serious form of pneumonia and highly on a percentage basis responsible for people being in the hospital and dying. The new shingles vaccine, Shingrix, I think is, again, something that I think is a reasonable preventive measure. There's some good data that does reduce the risk of developing shingles in a lifetime. Screening for Hep C has come out in the last few years. We have a decent blood test for this. The thought is that there's a lot of people in the baby boomer generation in particular who have chronic Hep C, which is a hepatitis virus that can affect liver, and who are asymptomatic. And unfortunately, because we now have drugs that treat this very effectively, once you have a treatment, then you want to go looking for more. And I think that's reasonable in this case because it's fairly tolerable, short treatment, and it can reduce the risk from having chronic Hep C. And so this is if I usually check it once, some tour after 50. If it's negative, then that doesn't need to be rechecked unless there's a change in risk factor. I think something that gets forgotten, and myself included in this, is the risk of falls at home and things like this. So a good preventive plan includes, how do we make sure you're safe in your home, particularly as you age? What's your fall risk? How can we reduce those risks? Because we know falls in the home are a major cause of morbidity, mortality in the over 65 group. And so I think a good preventive plan needs to be thinking about what's a person's mobility and balance in their home safety in terms of that risk. I think the future is so exciting. I think we're going to get much better definitive genetic mapping of what is an at-risk genotype for more and more diseases. There's this new test, and it's called the Galera test. You can go to their website, and there's some really interesting information. It's a new test that's been released this last year. It was this summer. Basically, what it's doing is looking at epigenetic, or the modification of genetic expression, and looking at methylation patterns with artificial intelligence, big data. And they basically are finding that they're able to determine risk for up to perhaps 50 different cancers based on different patterns that show up on this blood test. Very good data for up to about 12 different cancers. And the goal, again, this is not a preventive, but it's that early detection. For example, pancreatic cancer is most often not detected till it's already a stage 4. And so if we could more effectively identify a pancreatic cancer at a stage 1, then that's a more treatable, more manageable illness than waiting until it's stage 4. And that's true for all of these cancers. And that's the goal of this therapy, is early detection at a time when there's perhaps a better spectrum of treatments. I think we're going to see more and more specialized nutrition come out. Really, how do we optimize somebody's metabolic function that reduces the risk of diabetes and heart disease and hypertension? How do we manage inflammation? And I think one area that's really coming into full spectrum and will continue to be, I think, very big in both preventive and perhaps early detection is understanding the gut microbiome, which is sort of the major mind-body connection between the gut and the brain, the gut and inflammation. And so I think as we dive into that more and have better understanding of that, we're going to be able to really specifically, I should say, personalize everything from nutrition to supplements in a way to support that microbiome and keep somebody's gut healthy. And that has just dramatic impact for risk of diabetes and other metabolic disorders. And that is the end of my slides. I'm sorry about the earlier technical glitch. This is, I guess, not intended to be a complete overview of every specific thing, but I think the concepts of prevention and early detection and some guidelines for what to look for in a preventive program, and the important concept that lifestyle medicine, from my point of view, is the fundamental basis for any preventive health program. I appreciate the opportunity to present this information and people taking time to listen.